Thank you so much. So good afternoon, good morning, good evening, everyone. So we are from Group 6. We have actually two discussion. The first discussion about the health workforce shortage, and then the second discussion is about the recording and reporting system. So I would like to share the discussion on the recording and reporting system that we just had. So we have 10 participants. Thank you so much for everyone that actively participate in the discussion. And then for the challenge that we decide to focus on is from the Indonesia, and it's about the manual reporting and recording system for VPD surveillance that creates data gaps between national and also subnational level, and also challenge like difficulties in conducting analysis on the VPD surveillance data. So just as the background in Indonesia, that workforce, we also have the similar things with other colleagues. We have high staff turnover, especially during COVID-19. Most of our surveillance staff are being shifted to the other different units, and also limited health workforce to serve in hard to reach area geographically, especially in Indonesia. You know, there's so many islands here in Indonesia. And also we have some incentive issues for our surveillance staff. And then for the laboratory, we are grateful that we supported by quite number of lab. We have 3 polio lab, 7 measles and rubella labs, and diphtheria we have like 10 or 14 lab. So it's also good, but then still some problem in the reporting and recording system that cause delay in feedback and also incorrect result at some points. And also for the shipment, good thing that we supported by the courier and also third party that help in shipment of specimen from the health facility to the referral lab and then back to the health facility. And then the information system that be one of the focus that we still use the manual. Manual, it means that we really rely on pen and paper, and also using Excel application to compile and also to do the data analysis. It's not that we do not have the web-based, because previously we have a web-based system in I think 2014, but then it stopped due to some issues in the internal MOH. So currently we still use the manual, I would say, on the information system. For the applied research, we still have limited research being conducted in the area of VPD surveillance. And for the sustainable financing, good thing that most of the funding are from government, either at national or subnational level. And partners are mainly to cover the gap between the government from the funding from government, and also yes, we feel the gap of the funding. So for example, like we have 34 provinces and we support 11 provinces for the shipment of specimen, and then the rest covered by the government. And then the specific goal of the challenge is we would like to have a web-based recording and reporting system that link between surveillance unit at all level and laboratory, so that can minimize the gap of the data between field and also national level. Thank you so much. Experience has been shared from colleagues like Ethiopia. They use DHS2 as part of the IDSR project, and also other also use the DHS2 as well for their data analysis and also reporting recording system with offline mode of the application that will automatically upload the data once the internet network is connected. So it will very helpful as a benchmarking in Indonesia. And also in Canada, I know Canada is very well developed country, so the data, everything are well done, and the integration between laboratory and also health facility also there. So it's also good that if we can have the benchmark from the Canada as well. And also another, I think from Pakistan, they also mentioned that they also previously have a lot of parallel system that need some integration within one system. So yes, I think some countries also have the similar issues that we have so many things and needs some integration. So concrete action that the group was provided first is to have a roadmap on the development of VPD information system, especially to map all the information system available and to see how the integration can be done, and also develop plan, and then to collaborate with MOH to see which platform can be used, such as the HS2 or others that available and also had being used widely in the other country, and also develop training manual on how to use this system, prepare the staff on the recording and reporting, the new recording and reporting system, because sometimes or most of the time, if the new application or new system being introduced, it's gonna take some times to get to use to it. And then while we conduct or we develop all the system, regular data quality review need to be conducted to address the gap, so that we can, like maintain the quality, but also at the same time working on developing the system. Thank you so much. I think that's from group 2. Over to you.
Thank you. All right, I have you as group 6. Are you saying you're now group 2, Mustafa?
Group 6.
Group 6. Okay, thank you. All right, let's see. We have Melese Teferi with a hand raised. So let me ask Melese to unmute. Yes, what is your comment, feedback, insight you'd like to share with your group 6 colleagues?
Yeah, I'm really happy for by the presentation that as I identified the key points to be addressed. These points are also common for our groups at the same time. So when I come to the concrete action points, they need to train, develop training manual on how to use the system and increase staff capacity on recording and reporting. So literally two separate points. If they or once develop a roadmap for VPD infection information system, that may be the huge or the overall that maybe include these all listed activities like training manual, increase staff capacity, regular data quality review, and others. So these all are under the umbrella of the roadmap of VPD's information system, I think.
Okay, thank you, Melise. Roberto Talongua has a comment. I think it's a suggestion for concrete action. He says, can we not include ODK for Indonesia? Mustafa, any responses or follow-up to Melise's and Roberto's comments? Otherwise, we'll go to the next group after listening to Anna's feedback. All right. So, Anna, over to you.
Hi, yes, thank you for this example. And to answer yes, this is very important issues around information systems. And I do want to talk about that for just a minute, because we've talked, it's come up a few times, but I haven't focused on it as much. So we all know that for surveillance, one of the most important parts is the reporting. So if you have the staff, in an ideal world, if you had the funding and you had the staff, and you were able to go and collect information on every single case of every single VPD, but it didn't get reported properly, it doesn't help to inform the immunization system. So information systems are very important. And this particular example also made me think about collaboration. It can be within a country or even between countries. So for example, a training on a certain way of doing data input or doing data quality checks. There are many trainings that have been developed. Not all of them would apply to every situation, but there are probably trainings from maybe neighboring countries or from partners who are in your country who work in other countries who could give input on the training. And then when we get down to the specifics again of the country context, I like the comment about ODK. In some countries, ODK works very well. In other countries, it doesn't work as well. In this example, you gave, you said that there used to be a web-based platform, but it went away because of some issues with Ministry of Health. So now you're back to paper and pen. So we know paper and pen is not ideal usually because of so many transcription errors. Excel also can have some issues with accidentally overwriting data and things like that. So it sounds like maybe in this context, a web-based platform would be good. But again, it's country specific. So I think it's good to consider the web-based platform, something that could be available without internet or ODK if that will work in your context. So I just wanted to summarize by saying this was a good example of the importance of information systems. I know it's an issue in several countries, and I saw many good ways proposed to deal with this. So thank you.
Thank you very much indeed, Anna. And I know, let me see, I think Mustafa had, so we've deactivated. There have been too many people accidentally unmuting. So let's just hear, Mustafa, you wanted to respond before we move on to the next group, knowing that we'll be going until the 50-minute mark with the group presentation. So, all right, let's go to the next group. So that's Brenda, that's group 4 with Brenda Harriet. Ninsima?
Dr. Sulesh, I shared with you our work. So Dr. Sulesh is going to present on our behalf by mail. Please check.
Okay, I'm asking Sulesh Mekonnen to unmute.
Okay.
Well, I can't access Brenda. I think it's better to present.
All right. Maybe Celeste Mekonnen is not able to present. So I suggest we move to group 10. And please, group 4, if you can sort out your presentation. That way, we'll come back to you after we hear from group 10, Lokesh Alahari. A long time, whoops, sorry, I just muted you again by accident. A long time scholar, Lokesh Alahari. Look forward to your presentation.
Yeah, thank you, Reda. Thanks everybody for the opportunity. Actually, we, our group worked on 3 different scenarios and challenges in 3 sessions. So first one yesterday was on the financing. Today morning, we discussed on the involvement of community health workers, and the recent session we worked regarding the involvement of private sector in VPD surveillance. So I'll present the most recent one. So I'd like to thank everyone for their active participation. I'm just presenting on behalf of my group. So it's like inputs of everybody. So the challenge which Atom, the challenge owner, presented was regarding the non-involvement of private sector in VPD surveillance in South Sudan, and also weak medical council to regulate this private sector in the country. One good thing which came out was all these private facilities, many of them are busy with good pediatric caseload. They come across many vaccine-preventable diseases, but they're not aware of case definitions and tools for VPD reporting and not part of the surveillance network. During COVID-19 pandemic, they were part of the reporting network, and also they had their own labs for testing, and they used to report to the National Public Health Lab through the regular reporting system for COVID-19 surveillance. So the same thing can be leveraged and expanded to include VPDs and other disease surveillance going forward. Information system for VPD surveillance is nothing, no formal system is there at present. They need to be trained and introduced to the reporting system as well. Applied research, research has to be, the group felt that research has to be carried out to understand the capacity of their staffing and also what role they can play in VPD surveillance. And they can also be participating in research for VPD surveillance areas. So many of the private facilities or clinicians, they do research for their own purpose and they publish them. So some of them can be privileged for research in VPD surveillance areas as well. So that was one thing which came out. And financing, one of the aspect in private thing is they depend on their own financing and they think of their own profits. And they think that when a VPD case comes to them, it's more of treating the patient or treating the child. That is their main concern rather than benefits to the public health program as such. So that benefits need to be made aware to them. So we thought of financing in different perspective. So just to explain. And the ultimate goal was to convince private health system to be part of VPD surveillance and leverage sustainability for other disease surveillance as well. So COVID-19 surveillance has been has helped a bit. So this need to be carried on for other disease surveillance. So we talked of many country experiences as well. Many countries have different experiences. There are very good systems in place. In Nigeria, private health facilities annual renewal of licensing is linked to the participation in surveillance activities and routine immunization. So they had challenges, but this is keeping them in check a bit to report whenever cases comes. In Kenya, private facilities are incorporated into Kenya Health Information System, and they have to report even zero reporting, and they are being supervised. And licensing wise, the Kenya Medical Practitioner Council regulates private facilities, licenses them, and visits them regularly as well. Cameroon, private facilities are integrated into DHIS2 system, hence the supervision is through district health services, and hence it is easy for them to report, and also it is being supervised at the district level. So, but at every country we felt that there needs to be like regular sensitizations which need to be happening for private practitioners for them to report regularly. So few of the concrete action we could come out during this time: map all the private health facilities with high volume of cases and include them into the VPD surveillance network. Agree on legislative framework for reporting to the government. So the country should have this legislative framework, which many countries have. We had a couple of examples from Nigeria and Kenya as well. Sign MOU with MOH on expectation for surveillance. So what should be their role in VPD surveillance and other diseases as well. Linkage to renewal of annual licensing can be done to keep them in check, like Kenya and Nigeria are doing. Annual training and sensitizations regarding VPD case definitions and reporting. The group felt this is one of the very important thing. Though there might be legislations, there should be regular sensitization and training which should be happening in all the facilities at least annually. Feedback mechanism. So once they report the cases, there should be feedback from our end also. So government should give feedback on what happened to the cases, what are the results, what happened to the child or the case which got reported. So the feedback mechanism need to be established. Linking private facilities to the nearest county health department or the government hospital, so they can be in touch with the private facility in their jurisdiction for regular follow-up, sensitization, feedback, case investigation, sample collection, and so and so. So there'll be at local level some seamless work going on. Involvement and sensitization through private like pediatric associations. They'll be involved in the annual conferences or their activities through the association. So that also will be a good avenue to reach out to the private sector. So these were a few of the things we came up during our discussions. Yeah, thank you.
Thank you very much indeed, Lokesh Alahari for Group 10. I don't see any hands raised. I do see several comments in the chat. Perhaps Charlotte can help us pull out the gold nuggets from the chat messages. Charlotte, have you been able to follow the chat messages?
Yes, Reda, there is concerning this particular, and I want to congratulate Group 10 for the work. Presentation. There is this comment that I found interesting from Roberto Tatlongwa, who says concrete action or experiences useful for South Sudan. Use MOUs to break the silos between government health facilities and private health facilities. I was privileged to have conducted it with the non-profit health networks, namely FALC, OCAST, SEPCA, and then include public health missions when licensing private health facilities. So I think that was the other comments apply to probably previous presentations. And I see Adebutop Elisha that is thanking Group 10 for highlighting the gaps in surveillance in private health facilities is very important and applies to Nigeria, as well as it is estimated that 70% of health services are provided by these health facilities. The government has been making efforts to engage the private facilities better, but it has been quite challenging. Okay, I think that is it.
Yeah, that's great, Charlotte. Thank you. I see.
Thank
Eric.
you. Thank
Yes,
you
go
so
ahead,
much,
Luca.
Reda, and the entire scholar team. Also, I've been, like, as you told, have been associated with like scholar team since 2016. I think Jilmil Bal is also here. So I want to thank entire scholar team for all the great work you have been doing. Thank you so much.
Thank you, Lokesh. And I see Eric Maita has a hand raised.
Yeah, thank you very much. I want to understand from Cameroon, the experience from Cameroon, how they have been able to incorporate private facilities in the DHIS and whether they report directly and whether this involves all private facilities or probably those from high volume facilities only. And if they don't report, what is the measures they take to ensure that they report?
So question for Lokesh, do you want to respond? Are you able to respond to that?
Yeah, I think Pamela from our group would be like apt to answer this.
I'm asking Pamela Oben to answer, to unmute. Pamela, yes, would love to hear from you.
Hi, Reda. So for our country, we have a lot of private health facilities. And in my region, for example, and we have probably about 40% of our health facilities are private due to the fact that we have supervision from the health district and they have
Oh, I think Pamela's been muted. Sorry, apologies. I'm not sure what happened. Please start
VPD
again.
training. Yeah, hello.
Please start again, Pamela. I think you were
I
cut off.
said in my region. Hello.
Yes, we can hear you. Proceed.
Hello. Yes, in my region. In my region, the southwest region of Cameroon, we have about health facilities that are involving the old trainings. We have them we have focal persons that are involved in these trainings and who are responsible for actively carrying out surveillance. Also, they are also concerned with reporting their data in the district health, in the DHIS2, which is the National Health Information System. The supervision carried out by the district health helps them or monitors their activities. So this is what the experience I was sharing with the others. I hope this clarifies what was written.
Thank you, Pamela. Eric, does that satisfy your concern or what you wanted to know?
Yeah, it does, but I would wish probably to engage her further. I'll post my email address so that I can get more clarifications, because this is the same problem that we face in Kenya, and the reporting rates from private facilities is very low. So thank you for that response. Thank you. Bye.
Thank you, Eric. And indeed, if through this course, practitioners from Kenya and Cameroon can connect to each other and learn from each other, then of course, that is contributing to what we see as an important outcome for this course.